In the average family physician or average primary care visit in the United States today, average is 7 minutes logged with a provider.
Yeah, I've had shorter.
Yeah. We're in a world that is dominated by insurance, and the reason why visits and a little bit of time that you have with the providers and why it takes so long to get in is because the insurance controls how it's reimbursed. And everything we do is a business. Most of us that go into medicine, we want to help people. I mean, there's truly the want to do better for the world. But the truth of the matter is it's still a business, and you have to, fund the system and make the business work. Concierge medicine for me and for the Cove is about the relationship that you have with your physician or your provider. You cannot talk about lifestyle counseling in 30 seconds. But, the truth of the matter is that care does not happen quickly. We want to be the gatekeepers and help direct you to what's appropriate so that, we slow down the crazy imaging or the lab work that may not need to be done. And that's part of our system. And so if you're in a system where you can't spend any time or take care of these patients, it just, the whole thing blows up.
All right, today we are joined by Dr. Aaron Block, a dedicated family physician and a co-founder of the Cove Concierge Medicine in Castle Rock, Colorado, with a background that includes a Master of Public Health and a commitment to patient-centered care. Dr. Block emphasizes the importance of listening, understanding, and being present with empathy. At the Cove, he and his team strive to provide personalized health care that goes beyond traditional models, ensuring each patient feels heard and valued. So let's dive into our conversation with Dr. Block. Aaron, thanks for being here.
Yeah, Matt, thank you so much for having me.
Yeah, why don't you give your version of your elevator pitch, what you guys do and why?
Sure. So I'm a family physician, and one of the most important things that we start off with is, well, what is concierge medicine? You're a concierge doctor.
Yeah.
Concierge medicine for me and for the Cove is about the relationship that you have with your physician or your provider. We're in a world that is dominated by insurance, and the reason why visits and a little bit of time that you have with the providers and why it takes so long to get in is because the insurance controls how it's reimbursed. And everything we do is a business. Most of us that go into medicine, we want to help people. I mean, there's truly the want to do better for the world. But the truth of the matter is it's still a business, and you have to, fund the system and make the business work. So in the average family physician or average primary care visit in the United States today, average is 7 minutes logged with a provider.
Yeah, I've had shorter. Yeah, for sure.
Right? Granted, sometimes you really don't want to be there. But, the truth of the matter is that care does not happen quickly.
Right.
And we are taught this thought of shared decision making in what we do. So when you come and see me and I say, Matt, I know you don't like meds, but your blood pressure does not look great today. And you're like, yeah, I know. You told me that a couple times. So part of my job is to sit and talk about, why do I even care about your blood pressure?
Yeah.
What is it? What is the long-term, risk if we don't do anything? What are the risks of treatments? What are the treatment options? If you have 7 minutes to come in and, oh, by the way, we have to get your physical in, and, you need a referral to ortho because your knee hurts and you've got this rash.
That's it. Time's up.
Yeah.
Yeah.
By the time you want to talk about what you want to talk about, oh, I don't have any more time, so I'm going to put you on amlodipine 5 milligrams. I'll see you in about a month. And then you go out to schedule, and they're like, well, Dr. Block is kind of stacked. I don't think he has an open appointment, for 90 days. Then everything, this is such a common phenomenon, and people think that this is how it's supposed to be. So a lot of us in primary care are tired of trying to do really good work for people. I truly care about my patients,
Yeah.
sometimes to the point where it gets kind of annoying. Like I have to take some deep breaths, recenter my thoughts. Um, and trying to work in that model as a physician where I'm trained for shared decision making and holistic care. And,
Mm.
you need to know when to use medicine, but you need to know all these other options. And lifestyle counseling, that's
Yeah.
one. You cannot talk about lifestyle counseling in 30 seconds.
Right.
Matt, I'm going to need you to go to the gym. I'm going to need you to work out 5 days a week. I need you to make sure that you're having less than 2,000 milligrams of sodium every day. Make sure you're getting your fruits and vegetables. I know you don't like green things, but you're going to have to eat them.
Yeah. You just made me nervous. Yeah. I'm like, wait, what? Oh, I didn't catch all that.
Yeah.
Yeah.
Well, it's like those drug commercials too. You can have every single side effect under the sun.
Right.
It's going to happen. But you should talk to your doctor about getting this medication.
Yes.
Yeah. And so things are terrifying. And if you don't know your provider, if you don't know me, why are you going to take anything I say and
Yeah.
want to
Or
do
trust
it?
you.
Yeah. And trust
Yeah.
is a huge thing. Um, and so many of us have given up on that model because not only is it harmful for the patients, but it's harmful for us as physicians.
Yeah.
I spent basically another equivalent of kindergarten through 12th grade after graduating high school to get to where I'm at now.
Yeah.
And that included 1 year off.
Wow.
Yeah. And so I want to do things the right way. And so some doctors and providers are good at being able to check in and check out. They don't like to talk to their patients, and some patients don't like to be talked to. So there's really a space for everybody.
Sure.
But for patients that are desiring and starting to demand better, and for physicians like me where I have to find something better because professionally it was breaking me.
Yeah. You're not going to make it.
No. I'm 39. I have at least 25 to 30 years to practice from here.
Yeah.
I've already been in practice for about 8 years after training. I can't survive like that.
Yeah.
And so concierge medicine, and there's another branch of medicine called direct primary care,
Okay.
which, the problem is there's no clear definition of either. And we can kind of talk about
what
those
are the
different models look
differences?
like. Yeah. Concierge medicine started in the 90s. It was started by a pair of physicians that decided to start charging their patients additional fees, but still accepting their insurance. And what that allowed them to do is to slow down that hustle bustle.
Okay.
And back then, family physicians were seeing 30, 35 patients a day. I mean, you can't even get 10 minutes to talk.
Yeah.
And then you still have to do your charting and send the prescriptions and fight with insurance, et cetera. And so it's evolved from that. In early concierge medicine, there were some bad actors that were probably taking some advantage of this model. But a lot of us today are seeing it as a way where we can do really high quality care. Concierge, also, we do some really, white glove care.
Okay.
So when you're a member of my practice, we have a transparent annual cost. We'll break down that cost from annual, every 6 months, 3 months, or even monthly payments now. And for me and my model, there's that cost, and then we don't take insurance.
Okay.
So I don't care if you see me once a month or if you need to see me once a week, if you need to call me.
So people can, there's no limit to how often they can kind of come see you as long as they're paying the annual fee, the annual cost. Wow.
Yeah.
Okay.
And so, rightfully so, if you're a young 22-year-old and you have no health problems, you don't like talking to the doctor or having access, yeah, maybe I'm not the right model for you, and that's okay. But I have my youngest one patient in my practice is 21 months, which I still take care. I do full family medicine from cradle to grave. I just don't deliver babies anymore. And then my oldest patient is in late 70s.
Okay.
And so I really love to take care of that whole span of patients. But the idea is that, yeah, when you have an urgent need, if something happens in the nights or weekends and you need guidance, I'm actually there for you.
Cool.
And I'm happy to do that. And, you ring my line after hours. And if it's an urgent call, you hit, you follow the prompt, hit number 2, and it dials right to my cell phone, and I'm available.
How often are you getting late night calls?
That's the interesting thing. I'm not really getting tons.
Okay.
Granted, my patient population is still small. But my patients know that if it's not life or death, they can literally wait till the morning and call. And I
Sure.
can, my promise is also same day or next day.
Okay.
If you're investing in me,
I mean, if it's an emergency, they need to go to the hospital
yeah.
anyways. So,
But that's when I actually like patients to call, because I don't expect you as a non-clinician to know when you do need to go to the ER.
oh, okay.
So, I have a wonderful pelvic floor physical therapist that actually rents one of my rooms, and so
Okay.
it's fun because she does some amazing
Who's that?
work. Her name's Ashley Lytle,
Okay.
Dr. Lytle. I actually met her as a patient, and she has a background in orthopedic physical therapy, but she had so many patients that had so many incontinence problems or
Mhm.
lower back pain.
Yeah, we did some work for someone that does the same thing,
Yeah,
and she's like she does like online coaching for people. She's a doctor and pelvic floor doctor.
yeah.
And she was like, yeah, I have no shortage of clients. Like it's a huge problem.
It's so cool. And so we get to collaborate, but she had a family emergency, and as a friend, I help her out, but it's kind of the same thing as what I would do for my patients. Sends a text, or a message or a call and says, "Hey, this is what's going on. What do I need to do for my family member?"
Mm.
And I can say, "Well, if you can manage XYZ, then I will see you tomorrow, or your family member tomorrow, and take care of that for you. So don't worry about going to the urgent care." Or if it's, yeah, that sounds really consistent, like a heart attack, I would recommend going to the ER. Where do you want to go? I'll go ahead and call and let them know you're coming.
Wow. Okay.
I want to do
That's that
that.
white glove service.
Yeah.
Yeah.
The other model is direct primary care. And so this is a little bit of a lower cost model. So usually the price range on average is usually between anywhere from $60 to $150 a month. And then you have a little bit more a la carte service.
Okay.
Some people will charge, additional for visits. Some will limit visits. Some are unlimited charge. And then, everything else that you do in the office is usually there's a specific charge. I'll do point of care testing. So all of my patients, when you pay the annual fee, like I'll do 2 rounds of COVID, flu, strep testing.
Okay.
All of my urine testing is, covered, pregnancy testing. And then I do all the small procedures, and I only really charge, what it is the cost for materials and medications.
Wow. Okay. So,
Yeah.
all right. So, can we back up just a little bit? Because what you're offering sounds to me sort of like at least what medicine looks like in the movies in the 50s. You know what I mean? Like a doctor's coming to your house almost and like, taking care of you,
Mhm.
making house calls, like this, like really like a personal touch where your doctor actually knows you and knows your family, knows your medical history. Whereas like, I don't have a relationship with a doctor like that. If I have to go to a doctor, it's just pick clinic, drop in. You know what I mean? And they
Exactly.
don't know anything about me. I don't know anything about them. I just need some medicine, whatever, But how did we get away from that? What caused it? I'm assuming that's something to do with insurance. But like, how did we get away from that? Or was it a supply and demand issue? Just not enough doctors, too many patients, too many people, unhealthy people.
Mhm.
It's a combination of all those things.
Honestly, you're right. It is a combination of all those things. During my master's of public health, I actually had a medical economics course.
Okay.
It was really eye-opening. So it even talks about the strategies of insurance and how do you charge an entire population and use the healthy, population to pay for the sick population, and how do you
Mhm.
control payments with co-pays, co-insurance,
Was that class
deductibles.
sponsored by Blue Cross?
It actually was not.
Okay.
It was a pretty hard class. I had a great professor. But it was interesting because all of a sudden you're like, oh, I get it. I understand why you have deductibles and copays and coinsurance, because they are all deterrents from using insurance.
Mm.
Everything with insurance, the costs, when you're kind of like, my deductible's like $3,000. The reason that is set up is because they don't want you to use it.
Yeah.
They don't want to have to pay for anything. And that's the insurance business model.
Right.
Unfortunately, that really goes against my code of I do whatever I need to do for my patients. And some people are willing to spend money on healthcare, but the majority of people are not.
Right.
No one's like, yeah,
I
it's-
love spending money on healthcare. Yeah.
yeah.
Nobody's
I'm gonna
excited
spend
about that.
$1,000 and get a couple tickets to the Broncos game, and then we're gonna
Yeah.
go and
A vacation
have
sounds way
dinner.
better than some medical test.
Yeah,
Right.
absolutely. And we get that. We
Yeah.
totally know that. Unfortunately, a lot of our stuff is out of need. Um, and so the birthplace of insurance, are you familiar with that?
No.
So in medical or insurance in general, and then benefits tied to the workplace was a new phenomenon that came after World War II.
Okay.
So you had all these vets coming back from Europe, and one of the ways that jobs started to attract individuals was providing all of these benefits with working, because
Okay.
there was no such thing. And health insurance was generated as a result of that.
Okay.
Then when you follow medical history a little bit further in the 70s, a lot of the that's when we really started to have the American medical machine grow and develop. And so it was very difficult for physicians to do everything, because there's the business aspect that we do just as much as the medicine
Right.
aspect. And that's when the health maintenance organizations, or HMOs, came in.
Okay.
And then, super simplified version, but, fast forward today, and then it's, you have these mega giant corporations and actually insurance companies like United Healthcare, Aetna, Cigna, and they're buying
Hospitals.
they're buying hospitals, they're buying pharmacies, and they're actually starting to employ the physicians. And actually, it's not even beginning. I mean, this has been happening
It's
for a
happening.
while. And that's why
That's a crazy system. Like if you just look at the economic incentives, like I like to think like an economist. That's just sort of how my brain works normally. But so a lot of times I'm just like, well, let's just look at the economic incentives, and that's the outcomes that you're probably going to get.
Mhm.
It's like if you just look at the economic incentives out of that, it's pretty immoral and corrupt almost.
Doesn't it make you scratch your head?
Yes.
So yeah, for example, United Healthcare and United Health Group bought Optum and Optum RX. And so, in some ways, it's kind of a really interesting approach to try to streamline. So if you can streamline the insurance, the physicians,
Sure. That's their argument.
yeah,
right?
the medications. Yeah, but yeah, in all reality, it creates a lot of conflict.
Mhm.
We work in a complicated system.
Yeah. How much of just the paperwork and the hassle of having to deal with insurance was a deciding factor for you to go the concierge route and get out of that? Just, I feel like that's every doctor's office I go to or dentist, they employ like 2 or 3 people, even if it's a small office, they're employing a couple of people whose entire job is just to deal with insurance people. That's like, they just have to have like 2 or 3 extra employees just to get payments from insurance companies.
100%.
And it's like, and you're like, I've seen, TikToks and reels of doctors calling, and, they'll just record themselves. And then it's like, hey, my patient needs this. They're like, it's not covered. It's like, well, he needs it. And it's like, well, it's not covered. And you're like, okay, what do we do here?
Yeah, and unfortunately, I can't escape that. So if my patient needs a branded medication, and that's the neat thing about concierge medicine. So people also think they're like,
Gives you
I have
more
to pay
options.
for everything in cash. My services for primary care, all of your care coordination, everything in my 4 walls
Mhm.
is, under my fee. So yeah, I have the time to call your specialist. If I work very hard, I have Michelle's an RN. So I actually have a nurse that's trained in care coordination. So how do we talk to patients that need, that extra touch,
Yeah.
that need the extra reminders? How do we chase and follow our referrals? Oh yeah, I've got a good story for that one.
Sure, go for it.
So one of my patients was seeing a larger concierge medicine group, and the way that mine is set up, I'm part of a small affiliate with Miss Medicine. It's a really neat story to talk about too. But I am totally owned and operated. I'm affiliated with, maybe 17, 18 other offices, part of
Right.
Miss Medicine, but I'm my own beast. Some of these groups are a little bit bigger, and so there's more corporate models to create the concierge medicine construct, but it's for a lot of physicians that don't want to take on the work.
Okay.
And I don't blame them. It's really hard.
Yeah.
There's a lot. But I have a patient now, was seeing one of these concierge physicians, had a referral placed in February.
Okay.
Well, this patient became a professional colleague of mine and then was sharing their story. It had been like 5, 6 months since a referral had been put in. Okay, where did that referral go? So she sets up an appointment with her concierge physician and was like, we placed this referral in February. Like, where is it?
Yeah.
Um, and she was scolded by the concierge physician that she's paying money for that white glove service, that it was her responsibility to follow up on the referral.
Oh, gosh. What a terrible customer experience, right?
Yeah. And again, so, if you're not working in that space, then I don't expect anyone to understand referrals and how that works. And
I would have no idea.
stuff gets sent into cyberspace and IT.
Yeah.
And I still have problems with that. We've been open for 9 months and we're like, where did that order go?
Yeah.
I'm like, I know
It went
signed
up,
it.
but it never came back down.
Exactly.
Yeah.
So we have the ability, like in our electronic health record system, to set alarms. So if it's been 2 or 4 weeks and nothing has happened and the patient hasn't, told us that they weren't reached out to, our system alarms us. And so we track it and we
Nice.
chase it, and I, if I need to, then,
Is that software that just existed, or is that something that you guys are building?
Well, actually, that's part of our software and such, but we're also small enough and we care enough about our patients where it's like, it's top of my mind.
Sure.
So, I schedule my patients for follow-ups, somewhat regularly at first. And then I also tell them, if you don't hear from anyone within 2 to 4 weeks, I want you to call and let us know. And I don't expect my patient to chase it. We chase it for
Sure.
them.
Yeah.
And yeah, when you've got, 25 patients a day and you have thousands of patients you take care of and your inbox is something that, causes indigestion every night, your doctor's not going to do that for you usually.
No. And how can they? You know what I mean? Even if they wanted to, you know what I mean? They just can't. There's just only so much time in a day. So you said the average was 7 minutes. What kind of average are you guys like? What's a normal visit? How long are you guys spending? How much time do they get with the nurse? How much time do they get with you?
Yeah, and that's one of the things that we really pride ourselves on. All of my new patients are scheduled for 90 minutes.
Wow.
Usually with Michelle for, depending on the patient, somewhere between 15 and 30 minutes. And then they have a dedicated hour. And that whole first visit, I won't do physicals on the first visit, which I also don't charge for anymore. It's all built in. I literally spend time to talk about what are your goals? So Matt, so excited you've joined my practice. And how many doctors actually tell you they're excited? I tell everyone, I thank my patients profusely because they're helping me live my dream.
Yeah.
Getting to do work for them. What are your goals? What do you hope to get out of our relationship? What things have you been frustrated with your, previous doctor's visits or, your, with your provider? What challenges do you have medically? What are your interests?
Yeah.
Very interesting response. I will say typically men tend to be a little bit quieter about, some other thing. Oh, I'm fine. And their wife has dragged them in and then their wife will be like, did they ask you?
Tell them.
Yeah. And so I tell them, it's like, we can do a group visit together. A lot of couples are good for that because if you have one couple that, the one spouse won't speak up, the other one is happy to do so.
Sometimes the wives are just a little more in tune anyways, or vice versa. But you know what I mean? Sometimes it's just like, I wouldn't want to be a burden to my doctor. You know what I mean? Like, oh, I'm fine. So.
Yeah. And I get that. And oh gosh, I don't really want to ask that because I've already been told that I don't want to be a burden. And I have to remind patients, I'm like, I am asking you, I am imploring you to tell me what your
It's actually harder for you if they don't tell you.
It's exactly it. Yeah. But you're also accustomed to like, well, I saw, Dr. Smith down the road and, he didn't even make eye contact with me and they were typing on their computer. And I said I wanted to ask about the rash and they just grumbled and got up and left. I've heard so many stories like that. And it makes me so mad because it's time, it's money, and sometimes it costs people their health or their lives.
Yeah, and I think one of the things that about the medical field that I have a big problem with is like zero transparency.
Mm-hmm.
Even when they're like kind of trying to be transparent, I feel like it's not true. Like I went to like a ear, nose, and throat, and I think I have a deviated septum, and I just wanted to see because I can't breathe in my nose very well. And I was like, can you just take a look and see what's going on? And he's like, yeah, sure. And he's like, hey, I need to put this camera up there. and insurance calls this a surgery. So I have to numb it a little bit and I'll put this camera up there to look around. It should cost, $100 to $150 on your insurance, but it's a separate line. I was like, all right, if it's necessary, I guess. So we spray some stuff in my nose, sticks the camera up there a quarter inch, 3 seconds, goes, oh, yep, devious septum. I mean, and then I get a bill, right? I get a fast forward, 3 weeks or whatever. I get a bill for $300. And I was like, dude, and I called them and I was just like, hey, what happened? Could not get through to anyone. They just sent me in a loop, you know what I mean? A customer service loop. And I had no recourse except to leave a bad Google review and pay them their $300 and just never go back,
And it's sad. And we're
What a
all,
terrible experience.
it is a terrible
If I knew the
experience.
name, I would say it right now too. I don't remember their name. I blocked them out. But
Well, yeah, and I mean that's also controlled by the insurance. And
Right.
so here's something that is difficult too. You come to your doctor's office and you're just like, well, I see you take United Healthcare. And you're like, yes, we do. Well, I'd like to see you. And then we run their United Healthcare through the computer. And then you're like, oh, I'm so sorry, ma'am. Like, we don't take your United Healthcare.
okay.
Like, what do you mean? So
Yeah.
when you have a United Healthcare
It's so complex.
or you have a Cigna or you have a Blue Cross Blue Shield, there are so many versions because everything is custom tailored to the businesses.
Mm.
And so then they have these other things called carve outs. So this story, it makes my chest tight because
Yeah.
I fought so hard for this patient who was so frustrated. I had a gentleman when I was practicing in Dayton, Ohio. He was maybe late 50s. I'd only seen him once or twice. And he comes in and he just totally shares, opens up all of a sudden. I'm an alcoholic. I, drink, 2 pints of vodka a day.
2 pints a day?
Yeah. Like massive amounts. Yeah. What the human body can learn to manage is pretty
That's
fascinating.
crazy. Yeah.
I was like, I would not be alive right
Yeah,
now.
same.
And he was reaching out for help. We had a really wonderful, productive, affirming, visit, and just sharing, alcoholism is a disease. It's not your fault. We have to find a way to get you help. He had a carve out with his insurance that would cover things unless it came to any type of alcohol or drug rehabilitation. I could not get this guy anywhere for helping him get through detox. I mean, he was physically asking for help. I need to get off of this. I'm ready to do this. And when a patient is ready to make those types of changes, you move, mountains for them. I do that for my patients. When they're coming to me for help, it is time. And we were on the phone and my MA and she was working left and right. We searched for 3 days, I think, between Dayton, Cincinnati, Columbus, like all these areas.
Yeah.
We couldn't find a single person that could take him because there was such a specific carve out in his insurance. And unfortunately, in those cases, the next step is now you have to go to a hospital and sit in the ICU for detox because, it puts you at really high risk for some very
Which has got to
dangerous
cost
seizures.
so much more for the insurance company.
That is one expensive hotel.
Yeah.
And that bed is not so comfortable.
No. It's a terrible experience for everyone and it costs more money.
Yeah, it's just that stuff gets so frustrating. And again, going back to like some of us really care about our patients and how frustrating is it to work in a system.
Is there not a department of common sense at insurance companies? There should just be like, there's a department of common sense. If you have an issue that just makes sense, just call us and we'll resolve it.
Yeah. Well, in primary care and family medicine, primary care, which is also something to explain, like, basically primary care is who do you go to first? You're like, I don't know. And it doesn't matter if it's
I get sick, I'm not going to go to a podiatrist first.
Right. And even if you're like, I'm having terrible foot pain, my job is to help figure out like who is the right specialist if I can't take
it. It may not be the foot. It might be muscles in the leg or something,
Yeah. You may not need to see a specialist. You may need to see a surgeon or you may need to see, therapy or, and so, oh my gosh, I just got so worked up, I lost my train of thought. Where were we going with that?
I don't remember. We were
Oh,
talking. I said something
primary
about common
care.
sense.
Yeah.
You were explaining primary care.
So primary care. So the breadth of us is usually general pediatrics, internal medicine, which is adult medicine. OB-GYN does quite a bit of primary care, which is women's health. Then you have geriatrics, which tends to take care of our, older population, usually 60, 65 older. And family medicine is the one group where I actually am trained to take care of everybody. And so, within the care, the space of primary care, we want to be the gatekeepers and help direct you to what's appropriate so that, we slow down the crazy imaging or the lab work that may not need to be done. And, that's part of our system. And so if you're in a system where you can't spend any time or take care of these patients, it just, the whole thing blows up.
And a bunch of questions, but how do you build out your Rolodex of referrals? Is it how do you, that first time trying to refer someone to a specialist, how do you know if they're going to be good or not? How do you know if they're going to treat their patients well?
That's an awesome question. For the way that I function, I literally try to meet every one of my specialists. I want to look them in the eye. I want to ask them, are you someone that really cares about my patients? And I love to take care of, underserved populations in terms of ones that are not well thought of as underserved. So I really care about, LGBTQ plus patients. I just call them Q plus because it's too many letters for me to remember.
It's a lot of letters.
Right? It's a lot of letters. Just because these are really, good people out there that are misunderstood and therefore they're actually discriminated. And so in medicine, the other population that, my husband is my nurse practitioner, John, and he and I are both Menopause Society certified practitioners.
Okay.
So we are actually the specialists for menopause. We've gone through some rigorous testing and certification processes so that we actually know the science. I can't tell you how many women I've met that are struggling with hormonal imbalance, whether it's, early, middle or late, and how they've been told to embrace it, or this is just being a woman, you just got to get through this phase. It's just not true.
Really?
And so again, these are patients where I want to make sure that if I'm working with gynecology or urology or urogynecology, or if I'm dealing with a patient that has any type of malignancy, breast cancer, that I'm making sure that I have a really, nice and caring team for them.
Okay.
So that when I send a referral, it's usually a reflection of who we are as your primary doctors.
Yeah. I'm trusting you. You're sending me to the specialist. If I go and have a bad experience, it's going to reflect poorly on you. Are you asking for feedback from your patients? Hey, I sent you to Dr. XYZ. How was that experience?
Every single time.
Okay.
Yep.
Cool.
And I want to see if I got your consult note. Yeah. Oh, I totally do. Yeah.
Cool.
Because if you wow my patient and I've had a really good experience with you, we're called the gatekeepers in primary care because we decide where you need to go.
Yep.
That's also part of the model of keeping costs down. If you could just walk into a neurosurgeon, they would never have time to see anybody because everyone would be like, I have a headache. I need to see a neurosurgeon. When they do not want to see every single headache that pops up. And so, I want to know your full story. I do my best to be a really good diagnostician and figure out what kind of imaging do I need to do, what kind of labs. I usually try to find partners too, or I can, get their private, numbers and text them and just do a consult. Hey, I've got a 55-year-old, white male that's having, vision, these visual changes in the left eye, and he's getting headaches associated with XYZ. What imaging would you want? So
the same access that you sort of give your patients, you're hoping for from your partners. You're like, hey, I want to be able to at least just reach out and have a quick conversation, run things by you. So you need to be able to access those people.
Yeah. And the specialists are thrilled because there are a lot of, so go back to your 7-minute model, right? I've already been talking to you, Matt, about your blood pressure, and I'm throwing you on a medication, and all of a sudden you're like, and I'm snoring, and I don't know what's going on with my nose. Okay, well, then just go see ENT when maybe it had nothing to do with your actual nose. Maybe, you had sleep apnea and I
2
needed to
pints
do
of
a sleep
vodka.
study. Yeah, well, 2 pints of vodka may do that to you. But if I don't have the time to spend to really kind of differentiate all of that, I can't get to the bottom of it. So
Mhm.
primary care, as the gatekeeper, I also feel it's my obligation to really work up things as much as I can because it saves you time and money.
Yeah.
The specialists, there are, typically less of them. And so there's a reason why, right now with my local ENT guy, it's 2 to 3 months to see him.
Okay.
And he's great.
He's just busy.
Yeah. But so in the meantime, if I can get that referral going, hey, why don't we do a sleep study at home? I can order that and then we'll interpret the results. And then when you see the
Gives him more
ENT,
information to work
Mhm.
off, or her. Yeah.
Yeah, because otherwise, typically compared to primary care, specialist visits tend to be more expensive.
Okay.
They're fancier people, so they get to
Sure.
charge more money. And then if the first step is
It's that extra 2 years of school. Right?
yeah, right. Well, and sometimes something like cardiothoracic surgery, they're in training for so long that
Mhm.
I don't have a problem with that.
I've gotten to film a few heart surgeries.
Yeah,
Yeah, it was pretty cool. It
they're
looks like a little piece of raw chicken just sitting there. It's crazy.
just hanging out. Yeah,
Yep.
and very different than the cadaver lab. So as a first year medical student working on a cadaver lab, everything's a certain color, has a certain texture. Then you get into live surgeries as a student, you're like, wow, like this is
Different.
so
That's not
different.
what yeah. This has actual blood pumping through it.
Yeah.
So one thing I wanted to know, this is a weird little off topic, but like, how do you keep track of your patients and like all the notes and information? And then like, are you building in time to review that beforehand? And like, just how do you keep up with all that stuff?
It's a lot, and especially the way that I think is I'm so detailed and
Yeah,
systems
because I'm just
oriented.
thinking like you're getting so much information from them, and then they come back a month from now. Like, how do you recall that information? Almost like you go to a therapist or something. Like, how do they remember all this stuff that we talked about, 2 weeks ago or whatever?
Yeah, and usually it's a mix. One, when I actually know my patients, sometimes I can have conversation. Michelle and I can have a conversation about a patient that we saw a couple weeks ago. Like for example, we just got some labs back on a gentleman.
Careful,
The
HIPAA. I'm just kidding.
Hippo, what's that?
Yeah.
Well, no, I mean, that's the thing. That's why you can't identify this individual. But we got labs back on something that was pretty remarkable. So we can just pull up that name and talk about the lab. And, I can go like, hey, they were having XYZ symptom. And then this lab is like pretty groundbreaking as to like, hey, we found
Wow.
probably what the source is. And so, that stuff's really cool to be able to do. It takes a lot of work, and that's one of the least fun things of our job is the documentation.
Yeah.
So it's not just all fighting with insurance and the physical paperwork. It's, are we keeping really good records of things we talk about? And when I talk for a good hour, and if you can't notice by now, like I'm pretty good at talking to people.
You got great bedside manner, as they would say.
Thank you. Yes, that's my claim to fame. I can connect with people, and that's why family medicine was totally the right fit for me. But yeah, so, and sometimes there are novels written just because I really want to have good detail. Now, we live in a world where as AI is finally
I was going to ask,
catching up, these AI tools, especially in my job, are so groundbreaking and transformational in terms of how we do medicine. It's so much fun to see it. So fortunately, there are a lot of companies that are working very hard to make sure that it is ultra encrypted. I mean, we're probably like one step away from, government security, if not quite there. So I've got programs that basically will listen ambiently.
Yeah.
First, we had ones that it's just talk to dictate instead of, my dad is a family doc and old school. I remember him talking on his little recorder, and then they hired, I think her name was Carmen, this little lady, and she was just the happiest lady, and she'd just sit and listen to his notes and type all day long. Now, instead of even the dictation, directly on to the computer screen, in 30 seconds, it'll listen to my hour recording and it'll generate notes for me.
Wow.
Now, it's far from perfect,
Okay.
and
Yeah, I
these
have the
programs are
AI
quirky.
device called a Plod. Have you seen that?
Mm-mm.
Anyways, it's like a wearable device, and I can push a button and it'll record my conversation, and then it sends me the whole transcript, a summary, and then like some action items based on that
Oh, that's
conversation.
awesome.
So I'm sure you guys have things like that as
I
well.
need to look for one with a microphone because I can also tell that sometimes I'll be explaining something to the patient,
Mhm.
and then my note will say, "Well, the patient said blah blah blah." I'm like, "No, they sure didn't. I said that." So it does take a little bit of extra work, even with these tools
Right.
as they're
It's
learning
getting so
new.
much better though.
Well, and the rate of change is incredible.
Yes.
It's almost overwhelming. You're like, "Oh, I didn't know this changed," because everything else is changing along with it,
Yeah.
including the medicine.
Yep.
That's one of our
I can't
challenges
keep up.
as well.
I'm super interested in AI stuff, and I like, can I keep up? They come out with new things, or someone's like, "Oh yeah, I use it for this." I'm like, I never even thought to use it that way, like. So people are using it very creative ways.
Yeah, so that's definitely, a cost saver. And then they are in development of AI programs that will start to truly scrub the chart and go out there and collect. The challenge is that we don't have a unified electronic health record system. There are some
Is that
countries
something you're in favor of?
for one single electronic health record system and such. I
Yeah,
think it would be amazing.
For our country or for globally, or
I would start with country level. There
Sure.
are other countries that have done that. Thailand has a really cool system that I remember learning about when I was studying in my master's, that I think it's all controlled through their driver's license, or at least it was.
Okay.
So you could
Well,
go,
that'd be interesting to connect the two.
yeah, you could go to any
You can scan their
doctor.
driver license and pull their.
Uh-huh. And then you'd have their medical record. And so you could go to any provider.
Yeah. Or
and
if
it's
you're
all
somewhere
unified.
else, and you get in an accident and you're not conscious or whatever, like in an emergency
Oh,
situation,
that's a really good point too.
that would
Yeah.
be great to get their wallet out and scan it and just pull
Being
everything
able
out.
to pull that stuff up. Yeah. So I have patients, for example, Kaiser is a lot more locked down in terms of you can set a lot of the electronic health record systems to put things up on the Health Information Exchange, or HIE. And then there are other EHRs that have learned how to talk. And so you can put it up to the cloud and then pull it down as well.
Okay.
But, they'll have seen a specialist, and I was like, well, I can't actually see that note on any of the portals that, and I have to pay to belong to some of the portals as well.
Oh, wow.
Our
You still
EHR,
can't get them all.
no.
Hmm.
So it becomes problematic because then you start having duplication of services. I've had tons of situations where, and maybe it's because the specialists were not used to it, I was doing all the lab work, the imaging, I was working up my patients. I'd say, okay, this is where my diagnostic differential is right now. I want to send you to this specialist, and I want them to see everything I've done to, save time and money, etc. And then what do? They order all the same stuff again.
Oh, yeah.
So I'm like,
That's frustrating.
yeah, you can't fix some of that stuff.
But maybe that's something that AI. I'm optimistic about the future, so I think it's going to be able to help us with that stuff. I want to ask you about your business, about sort of the nuts and bolts of your business. What is the annual fee that you're charging? Are you offering like family discount if your whole family signs up? What does that look like?
Sure.
How do the packages break down?
So for the totally non-discounted single individual, runs $3,700 for the year.
Okay.
And then
That seems so reasonable.
I think so.
Yeah.
And this has been the interesting thing for the market. I've had some people that are just flabbergasted that it's so expensive.
It's $300 a month, basically.
Yeah. It's $10 a day. It's now it used to be 2 cups of coffee at Starbucks. Now it's about
Like
a cup and a
one.
half.
Yeah.
It
could be one fancy cup. Yeah. Everyone always breaks it down into Starbucks coffee. It's like just 1 cup of coffee. Yeah.
Yeah.
Okay. Yeah. But I mean, that's not cheap. You know what I mean? Like a lot of people live paycheck to paycheck.
And we get that.
And I can see how that would be an expense for someone in their 20s. It's healthy. That doesn't need to go to the doctor a lot. But
when you're thinking about, when I talk to families that are, taking their little kids to urgent care, and then you've got your copay for urgent care. And by the way, copays don't include all of the point of care testing.
Yeah.
So if you have a kiddo that comes for strep, the visit was $125, but you're going to get billed separately for the cost of the swab to look for strep.
Oh, you're doing, can you do all vaccines, like kids vaccines and stuff?
That's the one thing. Once we have volume, then I have the ability to bring a special company in to get that for me.
Okay.
So that's one thing that we're looking for. So it's a little bit challenging for kids. But the nice thing for us in Castle Rock is I'm not even 10 minutes away from one of the Douglas County health departments.
Okay.
So I can very easily coordinate that with the health department. And then all adult vaccines are carried by the pharmacies. So, I go through and say, hey, we're needing your tetanus and your shingles, and we need to update your pneumonia vaccine. So I can send those scripts over to the pharmacy and patients can just go get it that way. But yeah, and so within that $3,700, yeah, we do 2 rounds of COVID flu, strep testing. I do offer RSV testing for maybe about $20 just because that test is a lot more expensive than the other ones to get. I am still trained
The
like a
fact that you're upfront about the cost
yeah.
is so like just no one else does that. You know what I mean? Like you just hey, you need this, this, and this. You're like, okay, is this gonna cost me $100 or $2,000? I have
Yeah.
no idea.
And I want to know that for you. The same thing is that when we're looking at certain medications, and if I know it's not a typical cheap generic that I'm not familiar with, even this happened to me this year. So one of my medications that I needed at the pharmacy, I went to go pick it up, and it was like 90 some dollars. And when I checked the apps like GoodRx to see
Yeah.
what cash price was, $23.
Yeah.
So with my insurance, it was $70 more expensive. I actually will sit with my patients during my visit because I have time to do it,
Yeah.
and we'll look it up together.
Yeah.
And so, I'm not sure about this medication. I don't write it for, as often. If it is more than $50 as it says that it should be on this price, tell them that you want to run it through GoodRx. So I even spend time teaching my patients, like, how do you be a good consumer?
Yeah.
How do you get the best price?
I mean, in that way, you're, and probably paying for your own services in a lot of ways,
I truly do. And I've done it before.
Like if you think about the math, the economics of it, I pay you $3,700, but you're also going to save me, $1,500 on medications and a test and other things like that.
Yeah.
Then you got to think about it like that too, I think.
Well, the other cool thing that I, tell my patients that I'm like, please use me for this. So let's say you and your family are off to Fort Lauderdale for a beach vacation, and you pick up something and you are super sick, and you just can't keep, you're super nauseous and you're vomiting and you just can't keep it down. I want you to call me first and tell me, and let me see if I can call in a cheap, medicine for nausea at the pharmacy for, $10.
Yeah.
Rather than you spend $125 on an urgent care copay and the hundreds of dollars that you're going to spend on your point of care testing until you reach your deductible.
Yeah.
And same thing for all of that. And then I'll tell you, like, but these are the signs. So if you're starting to have difficulty like making sense in your head, or your blood pressure's all over the place, and you can't hydrate, that's when I want you to go.
Then go in.
Yeah. And then let me know where you're going, and I'll call them and give them your information. And, so I can, I actually want to save my patients money, even though I charge them cash, because I'm cutting out the middleman.
And you're teaching people how to use you.
Yeah.
Right? You're like, hey, here's how you can use me and my skills and my services, which is what I offer. So in a lot of ways, I just feel like you save people so much money that it just kind of makes sense.
It really does. But the thought of paying cash for
On top of
yes,
your I'm already paying insurance.
And totally get that. And so the other discussion that we like to have, so my father just retired from the state of Ohio's Medicaid, department. He was second in command for a couple of years, has worked in managed care, Medicare, Medicaid space, has worked in insurance companies. And so through both my practice, my master's, and then watching his career, I have a really good understanding into the challenges and why the insurance, industry is so it's complex.
Yeah.
And so, just because you have something offered through work doesn't mean that's your only option. One of the gentlemen that I know down in Castle Rock has his own insurance brokerage. So he can literally sit with you and figure out what your needs are. So if you're a young 26-year-old male and you really don't have any medications you're on and you don't go very often, and if your insurance through work is going to be $500 a month, with a deductible of $10,000, maybe he can do better for you. One of the things that we are trying to do as well, and we can get into a little bit more about that, is I actually am trying to work with businesses for an alternative structure.
Yeah.
And what I've found is, because I do preventative medicine, and these are qualified medical expenses under the IRS tax code, businesses can actually use my services, get concierge level care, and it can be paid for through small businesses.
Okay.
Which is really fun. But yeah, going back to, cost and such, if I can get a couple, and again, I love the family care
Yeah.
aspect. It's super fun.
Yeah.
I love grandma and grandpa and the cousins and, all the little ones. So I actually price it so that it's really competitive so that I can entice families to come.
Okay.
So for couples, I'll see a couple for $59.50,
Okay.
which is like, over a $1,400 discount from what it would be if two individuals.
Yeah.
And then if you're a member, I'll see kiddos for $500 a year
Oh, wow.
because I just really love seeing them,
Cool.
and it's super fun. So I can take care of a family of four for under $7,000, and
Okay.
it's unlimited access to me.
Okay.
It's not 4 visits and that's all you get. And then, all of our other, the procedures I do, I love doing cysts and lipomas. So I do all my own derm stuff.
Oh, wow.
So I can usually do the first level stuff. If I, biopsy and I think it's melanoma, I actually know how to do. I usually melanoma just because of how complicated it can behave. I usually like sending to dermatology for follow up, but I can usually do the diagnosis so that we can get you right in. And so
Yeah.
I'd say this is what it is.
And the fact that you're taking the time to look for those things as well. Just
Yeah,
like-
do you know I'm 39 years old. I'm hoping that maybe when I was a child, but no one's ever asked to take my clothes off and look at my skin. That is built into every one of my annual exams. We don't do gowns, we do robes and we put them in a nice heater.
Nice.
So you've got a nice warm robe. And then I asked just to look at the skin around your body, especially the places that you can't.
Yeah. Yeah.
And I spend some time talking about the ABCDEs of moles.
Yeah.
To look for, early signs of cancer.
Why don't you run through those real fast and we'll clip
You want to see if I can actually do
No,
it?
no, but we'll clip it for you because I think it's really important. I think
Yeah.
my wife is an epidemiologist, and so she's a research professor at CU.
Oh, well,
And,
now I have to meet your wife because I'm such a dork because that's in the field of public health.
She would.
so I
She
love
could talk to you
that.
for hours. So she studies cannabis use in pregnancy, and she's
Oh, wow,
she's got
yeah.
a couple big grants. She's studying the health outcomes of the baby. She's got a big grant where she's studying the moms and the babies and their health outcomes for like 7 to 10 years. But
That's so cool. Yeah, because when I delivered children, we had a lot of, moms that were very heavy marijuana users and, babies were, had detectable THC levels. And
Yeah.
so we had to, help them wean through that difficult
mm,
process. But
yeah, and I think
very cool.
physicians right now don't know how to address that and talk about it necessarily.
We don't.
And because there's not a lot of medical guidance, I guess it's like, well, we know what to do with because of research. We know what to do with cigarette smoke and alcohol, right? And we know that those are bad. But I think because cannabis use is now that it's legal and it's still pretty new, I don't think that it's been studied enough. We don't really know how to tell physicians how to deal with it.
guide.
And how to talk to moms, pregnant moms about it. So
Yeah, well, and that's true. I mean, if it was, a Schedule 1 drug, which means that it's not a legal drug, a lot of times there's no funding to spend money on that.
right.
So as soon as it became something that, the population could access. So yeah, I'm a dork when it comes to all that too.
That's cool.
Yes. So the ABCDEs of moles and looking for skin cancer. So it's a very easy mnemonic. I teach my patients, I make them teach it back to me so that they know. And I've had some patients that, made me like a super proud parent. They came in and they're like, look, it violated D for diameter. And so I wanted you to come take a look at this mole. And I was like, good job.
Nice.
A is asymmetry. So when you look at freckles and moles, it doesn't look like it's pretty round and symmetric. If you've got one side that's nice and round and the other side is jagged and looks like it's all over the place,
Okay.
put your, red flag up.
Okay.
Doesn't necessarily mean it is bad, but it means we need to pay attention to it.
Let's keep an eye on it.
Yeah. B is border. Border means we're looking to see exactly where the mole starts and where the mole stops. If it looks like the mole starts to kind of just, integrate into the skin and you can't see where it starts and stops, that's something that
So if it doesn't have a good solid border,
correct.
then okay.
Yeah.
I'm checking this one out.
Yeah. So I always use my freckle. I'm like, I can see where it starts. It's round.
Yeah.
C is color. So any of the browns, tend to be okay, whether it's light to dark. But anything that's blue or black or purple, not necessarily bad either, but melanoma oftentimes, presents as black
Those
or
why people
sometimes
with darker
blue.
skin also suffer from this a lot worse because it's harder to detect.
Much
right?
harder, yeah.
Yeah.
So when you have, the really deep, chocolate brown, almost black as night skin, the moles tend to be harder to determine. Um, the nice thing about having those darker skin tones is they also have much higher levels of melanin, and which is actually protective.
Yeah.
But just like anybody else, when you're out in the sun, they may not burn as much as, when you're pale and white like I am.
Yes.
But there's still that risk. So yeah, A, asymmetry, B, border, C, color, D is diameter. So anything larger than 6 millimeters or the eraser of a pencil.
Okay.
If you remember what those are.
Yeah. I'm old enough. I'm 40. I know.
I was going to say, we're probably, I'm 39 as of today. So,
Oh, yeah.
So we're there. And then E is evolution. So I always tell people if something is changing and you're watching it change,
so it's changing. Yeah.
then that's probably our biggest risk factor.
Okay.
If something was really well behaved for 20 years, now all of a sudden it's scabbing and it's itching or it's bleeding, I want to see it.
Yeah.
And, worst case scenario, we start with, a biopsy, and either if I can remove it completely from the skin, I'd love to do that.
Sure.
If it's concerning for melanoma, I may do a different type of biopsy so I can get some depth, because depth in melanomas is really important. Send it to the lab. But yeah, just by taking your skin off, following the ABCDEs, paying attention to things. I've caught squamous cell, basal cell, even melanoma.
Wow.
And I'm actually trained to do the full excision. So if you're in my practice, rather than, trying to get you into dermatology, which some of these practices are almost months now because they're so busy, especially in Colorado. And I trained in Florida, so everyone had skin cancer down there. But yeah, I can literally say, okay, well, I've got 10 minutes. Let me get all the supplies, and then I can send it for biopsy. And then depending on that, I can make sure that we have appropriate, if I need to take appropriate margins, if it's a true cancer, then I can do that, close you up, and then it's gone forever.
Wow.
So
that's great.
Yeah.
Again, saving people tons of money, probably.
Yeah. And the nice thing
and
is
catching it so early, like taking the time to sit with them and learn, because maybe it's not even something that they would have thought about coming into that appointment, right? But the fact that you had the time to sit with them, talk with them, bring that up, and then like, oh yeah, there's a spot. My husband pointed it out. Like, do you want to take a look? You know what I mean? Like, you could save their life. You know what I mean? Like, that's huge value.
Yeah. And you can't do that in 7 minutes.
No,
I mean,
you can't.
that statistic just, again, continues to blow me away. And I'm
Right.
like, so that's just the reminder, all of these things that we talk about and want to do. And you want to talk to your, when you have someone you can trust. I've had a couple of people that are like, I don't need to talk for an hour. And then I start asking the right questions and the open-ended questions. And we fill that hour every single time.
Yep.
Because it's nice to, have someone that, we know the data and what needs to be done for people. And in the end, it's really, again, about good quality care and finding a solution to a complex system, and being able to provide good medicine.
Awesome. Hey, let's wrap this up. I want you to maybe just tell us, like, who's your perfect client that you're looking for? Like, who is your, I mean, it sounds like you kind of can see anyone, that's the benefit of family medicine, but like, who, what's your perfect, client avatar, I guess?
Sure.
And how can they tell us how they should reach out to you? What's the best way to reach out to you?
Sure. So, at the Cove, I am really looking for patients that are invested in wellness and that want to be well. Doesn't matter how complex the medical history is. I tend to work a lot with patients that have been traumatized by the medical system. I don't like going to see the doctor. I hear that all the time. I want you to feel comfortable in seeing the doctor again. But being able, I want someone who wants to sit down and being able to have good conversations, being open to learning about what the science says, being cautious about what they see on social media.
Sure.
And then it's my job to educate and, do the shared decision making and figuring out what we need to do for those patients. So it doesn't really matter, age, gender, how much money they make, really anything. I love taking care of all populations. I'd say one of my specialties, definitely women that are struggling with midlife changes, perimenopause and menopause. We are menopause specialists are a relatively newer phenomenon, and for years women have been totally ignored, pushed aside, and just told, yeah, that's what it is. And they don't have to be miserable anymore. And so there's a lot of science-based options to do better for them.
Awesome. And then what's the best way for them to reach out to you?
Sure. So website's very easy to get to, thecovecm.com. We love people to take a look at our website and send us an email, or direct phone number. It's 303-970-8190. And we are happy to take everyone's call. We do free meet and greets. So we really want people to interview me just as much as I want to interview them, see our space, and decide if it's right. There's never any pressure for patients to make that decision if they need time to figure out if I'm the right fit.
Amazing. Well, you give me a lot of hope for the future of medicine. So thank you for your time today. Appreciate it. And it's a great conversation. I appreciate you.
Yeah, thank you so much, Matt. I appreciate you.